anaerobic bacteria can cause significant life-threatening infections, and one of the problems with anaerobes is we generally do not send anaerobic cultures. So it's invariably presumptive treatment with empirical agents. Because we don't send cultures, we don't get an organism, and because we don't have an organism, we don't have the culture sensitivity report. So we need to treat anaerobic infections on clinical grounds and look at the response to the drugs that we use again on clinical grounds. The sites where we suspect anaerobic infections are the tooth and gingiva, so the oral cavity, ear, nose, and throat infections, especially if they are associated with suppuration, abscess, necrosis. Then the colon, so the entire abdomen is susceptible to anaerobic infections, especially if there is a breach in the anatomy, the pelvic area, and the vaginal area. And this is because the anaerobes remain in these places as commensals: the oral cavity, the nose, the colon, and the vagina. And because of certain changes in characteristics, the organisms at these places can become the cause of an infection. The anaerobes are highly susceptible to oxygen because they lack superoxide dismutase. This is the enzyme which neutralizes the free radicals which oxygen generates. And there are other enzymes like catalases and peroxidases which prevent the formation of these free oxygen radicals. So when you have a mixed infection with an aerobes, the aerobes, they consume the oxygen, reduce the local tension of oxygen, which is very conducive for the anaerobes. Some of them are obligate anaerobes. They cannot stand even small amount of oxygen, or some of them are called microaerophilic. So they can stand a little concentration of oxygen, but a higher level will kill them. So when you have an associated aerobic infection, it is actually good for the anaerobic organism. And the other issue is that anaerobes of different types can cause infection. So it is multibacterial, both in terms of different anaerobic bacteria and also in terms of aerobic and anaerobic bacteria together. Whenever there is necrotic tissue, there is abscess, there is phlebitis. These are the common areas where the oxygen tension will go low and anaerobes will thrive. And anaerobes, they are very good at causing tissue necrosis, formation of abscesses, because that decreases the oxygen tension in those areas and produces an environment which is conducive for their growth and survival. They produce lytic enzymes and chemicals to cause necrosis and abscess formation, and some of the anaerobes like Clostridia, they produce powerful neurotoxins. So you have Clostridium botulinism causing botulinism, and then you have tetani, which causes tetanus, and then you have the Clostridium difficile, which causes C. difficile diarrhea. The anaerobes are both gram positive and gram negative, and we're just dividing the most common ones. The bacteroids, which is a gram negative anaerobes, is the most common cause of an anaerobic infection. And then we have the Fusobacterium, Porphyromonas, and Prevotella. And among the gram positive ones, we have Actinomyces, Clostridia, Peptostreptococcus, and Cutibacterium. These account for the major infections associated with anaerobic organisms. Now, what are the agents that we have to treat anaerobic infection? We have the nitroimidazoles, the most talked about, which is metronidazole. You also have tinidazole and secnidazole. Then we have the penicillin derivatives. As we know, penicillin has anaerobic cover. The problem which happened with penicillin was anaerobes can elaborate beta-lactamases and they can hydrolyze penicillin. The aminopenicillins are better suited, especially with the BLI partner. So ampicillin sulbactam, amoxicillin clovolinate, they have fair anaerobic activity. So is with piperacillin tazobactam and carbapenems, which probably, other than the nitroimidazoles, have the best spectrum of cover for anaerobic organisms. Then we have the lincosamides, clindamycin. Among the quinolones, it's moxifloxacin, and among the tetracyclines, it is tigecycline. In fact, tigecycline intra-abdominal infection trials were done with monotherapy with tigecycline. So it has an excellent anaerobic cover. And whenever we talk of abdomen, it's bacteroids which should be covered, and tigecycline covers it. Cephalosporins in general, other than the cepamycins and aminoglycosides, have poor anaerobic activity. So they will not cover anaerobes. Other antibacterial agents may have decent cover but may not have a broad cover. Resistance to both carbapenem and metronidazole has been seen, and metronidazole, especially in the Southeast Asian nations where it is used very frequently over the counter for diarrheal illness, there it has been seen that there is presence of resistance among the anaerobes. Now, one of the problems with anaerobes is what to do if we isolate them in smears. They may be there as commensals. They may not be responsible for the infection. Tissue samples and cultures may also represent colonization. And as I said, anaerobic cultures, you have to order it from before, because that is how they are collected and sent and then the culture performed. This we do not do in our unit at all. Some organisms produce spores like Clostridia, which may not be killed by alcohol hand wash, and soap and water is thus necessary. This is from the infection control point of view. So whenever you have a clostridial illness like a C. diff related diarrhea, we need to understand that to stop the transmission and to kill the spore, we will require soap and hand wash. For some of the anaerobic infections, the diagnosis is done by the detection of toxin in body fluids, like for botulism, like for C. difficile. For tetanus, there is no such test, but for these two, it is about the isolation of the toxin which is associated with the infection. Tetanus is more of a clinical diagnosis. I also make a comment on actinomyces, because here tissue biopsy is of help mainly because of the sulfur granules that they produce. The characteristics of the necrotic tissue associated with actinomycosis, this may be helpful in diagnosis. And metronidazole is ineffective. So one anaerobe where metronidazole doesn't work is actinomyces. Aminopenicillins are good choice. They generally do not elaborate beta lactamases, so you do not require a BLI inhibitor along with the penicillin. What about the bacteroids? The most common cause of an anaerobic infection? It's generally the anaerobe which has shown maximum resistance, and this is of clinical significance, especially if we are treating empirically for intra-abdominal anaerobic infection. In fact, bacteroids are almost usually associated with abdominal anaerobic infection. They may elaborate both ESBL type of enzymes, which is the AMBLA group A, and the MBL types, which is group B. And we know when MBL is elaborated, they destroy all the cell wall active agents except the monobactam. So which would mean that if bacteroids can be resistant to carbapenem as well because of the elaboration of MBL, although the incidence is very low. And also we might require an agent with a beta lactamase inhibitor, or maybe a carbapenem or another agent if an ESBL type of enzyme is elaborated. Clindamycin is not of great use for bacteroids because of a high incidence of the prevalence of resistance, almost reported as 40 to 50%. And not only clindamycin, this whole MLSKO group, macrolides, lincosamide, streptogramins, ketolides, and oxalizolidinone. So all of them have anaerobic cover, but they are not as reliable as the other antibiotics I discussed with, which have excellent anaerobic cover. And when it comes to bacteroids, they are better avoided. Moxifloxacin does have activity against bacteroids better than the other quinolones, and tigecycline also has excellent activity against bacteroids. In fact, tigecycline can be used as monotherapy in intra-abdominal infection. The most reliable drugs for anaerobic infection still are carbapenems and metronidazole. We do not know if there are clinical situations where we might be using them together. Let's say an intra-abdominal infection, you're not very sure. It is a bacteroid likely to be involved, and it could be multi-drug resistant. So that is a choice that we make. Otherwise, we may choose one and avoid the other. So if we are using a carbapenem already, we may not require additional metronidazole cover. We also need to understand in majority of the clinical situations, a drug like metronidazole, which is mainly for anaerobic organisms, might be used with agents which have cover over other bugs which might be involved in infection. So there could be other aerobes, other gram-negative cocobacilli which could be involved in the infection, like in a necrotic tissue, a burn wound, maybe a severe trauma, bacterial intestinal perforation. So there it might be that the likelihood is polymicrobial, and we might require a cover both for an aerobe and an anaerobe, and our choice of therapy should depend accordingly. So one of the major problems with anaerobes is we are almost blind. We do not know, we make all presumptions. Sometimes we may be lucky with isolation of the tissue showing the organism, some characteristic like in actinomyces, but otherwise it will be always clinically guided.